Thank you very much. It's great to be here. Well, thanks very much for inviting me. And those who were at the Rotman Dialogue yesterday, well, this is something of a continuation, so that this paper sort of condenses a lot of what I've been thinking about over the last 2 years in the context of ways in which some philosophers have also failed to notice some problems about justice in health systems, which have become particularly salient, I think, over the course of the pandemic. Okay, so there's a big literature on resource allocation, both within health economics and also within bioethics and philosophy. So they're probably, if you're sort of familiar with this literature at all, you're familiar with names like Norman Daniels or sort of the idea of measuring health benefit through the quality-adjusted life year. And so I've made a lot of contributions to this literature over the last 10, 15 years, but that it presupposes a certain kind of paradigm about how to think about scarcity in healthcare, a paradigm which, over the course of the pandemic, I came to realize, I think, was mistaken in various sorts of ways. So just to sort of get us started, sort of the baseline for the way a lot of philosophers have thought about this problem is as follows, so that to start off with, pretty much everyone assumes that scarcity is just going to be ubiquitous in healthcare. So that Ronald Dworkin has a number of famous arguments where he says that, well, healthcare is just potentially a bottomless pit because there's pretty much always additional things that you could do in an ITU to prolong someone's life by a little bit. So that either you devote pretty much all the resources you have to trying to improve people's health, or you say that you've got to draw the line somewhere. So that somewhere he thinks we'll realise that, well, scarcity is something we have to live with in healthcare just because there are other goods which are competing with it. But the obvious difficulty is that scarcity is a rather bad thing when it comes to healthcare, because people need healthcare because they're sick, they're suffering, they might be dying. And so when there's a scarcity of healthcare, some people are not going to get care that they need and may die as a result. And obviously, it's not at all a comfortable position either for doctors or indeed policymakers to be in, to have to admit that some people are going to get sick or die because we haven't allocated enough resources to healthcare. So over the course of the COVID pandemic, we saw quite a lot of new literature, new debate about scarcity, and that some of the things suddenly became salient which hadn't been so salient before, so that many countries saw a sudden sort of shortage of PPE, personal protective equipment, so we had to think about how we rationing this, who gets to use the best quality masks and in what kind of context, or think about the rationing of access to ventilators, which was a huge issue in the early part of the pandemic. Another issue that became newly salient was the idea of scarcity of staff time. I guess, again, if you're a healthcare professional, you're aware that sort of your time is always limited in a certain way, that time spent with one patient is time not spent with another patient. But suddenly you had a massive spike in healthcare demand with a much depleted healthcare workforce and people trying to keep all that covered, and you saw a massive rise in staff burnout, moral injury, moral distress. It's something I'll come back to towards the end. But the thing that I want to focus on today, which not many philosophers have talked about at all, is what I call cascading scarcity. So that what we're seeing increasingly in healthcare systems, either during COVID or as a result of some of the difficulties that COVID brought about, is that scarcity in one part of a health system leads to scarcities elsewhere. So you have increase in waiting lists in one part of your health system, which has knock-on effects all across the health system, which makes things much worse for a wide variety of patients. So I'm interested in this question of cascading scarcity in healthcare, how to theorize it and begin to think about what to do about it. And I'll suggest various reasons why it is that it's a problem that's quite difficult to tackle with a lot of the sorts of tools that philosophers have usually used. So one thing that I found interesting was that if you do work in global health, then you'll probably notice that questions like sort of health system resilience, they've always been talked about for the last sort of 20 or more years when people are thinking about very poor context. But suddenly we realised that, well, health system resilience was a huge topic for health systems, whether in Canada or the UK. And things that are, in retrospect, obvious, but we hadn't thought about ethically enough, such as the fact that, well, many health systems are trying to make themselves as efficient as possible, and that particularly have a publicly funded system like in Canada or like the UK. There's always this question about, well, how much can we justify paying out of the public dollar, which then often will lead you to think like, well, we shouldn't have sort of hospital beds that are being unused, you cut back on those as much as possible. But then suddenly it turns out you have an unexpected healthcare crisis much larger than you thought. It turned out that, those beds would have been really handy. And so you begin to realise that, well, resilience and with that the need for spare capacity is a really important part of what makes a health system good. But it seems to be in tension in various sorts of ways with the question of what it is that makes a health system efficient. So I'll introduce a term of art which will be crucial for what goes on later, the idea of health system optimization. So I define it in broad and sort of vague terms as the processes by which policymakers aim to deliver the best health system possible given financial, broader resource and other constraints. So I want this to be us to read this in a deliberately broad and inclusive way. So I hope that everybody will agree that, as it were, policymakers should be aiming to optimise health systems. What it is that we're going to be arguing about is what does it mean to optimise a healthcare system? What's the best conception of optimisation? And anyone who's read the book will notice that I'm sort of slightly, well, I would say obsessed, but maybe certainly interested in complex systems, and systems theory is a way of thinking. And so it probably won't surprise you very much to say that there's going to be an emphasis on that in this talk as well. And so that often we overlook the fact that health systems are systems. And like all other systems, what they do is they transform inputs into outputs. And obviously in the healthcare system, there's a wide variety of things which could count as inputs, so that money or staff time or pharmaceuticals or medical equipment. And then we have a variety of processes within the system which transform those inputs into outputs. So it might be that you put a team together, you successfully operate on somebody, remove their appendix, or you build a new medical device, or through a new policy you achieve a reduction in health inequalities. And that also the inputs and outputs are related together in an iterative way. So think of something like a randomized controlled trial, so that you do the research, the outputs of that will be some published papers. Those published papers are then an input for further processes within our broader healthcare system. Somebody wants to do a systematic review, they review your RCT, then you publish your systematic review. Somebody then takes the systematic review, uses it as a basis for reforming good practice guidelines, for example, so that lots of things are inputs at one moment, they use it, become outputs, then become inputs again. So, and this is all related together in kind of dense interconnections. And so another crucial concept that we'll be talking more about is the idea of a flow. And by a flow, I just mean, just to define it, a process by which inputs are transformed into outputs within a system. So that, again, thinking of a healthcare system, we have a wide variety of flows. So obvious ones will be flows of money as they move across the system, so that you have to track what care is provided to patients, and then doctors or hospitals are reimbursed on that basis, or that patients themselves move across the healthcare system. They might go first to a general practitioner in primary care, then be referred to a specialist. Maybe that specialist can't help them; they get referred somewhere else. And you can see that a patient has a journey across a healthcare system. That's another sort of flow. And so that one of the things that sort of working as I have a lot with data in our National Health Service in the UK has taught me is that often there's an incredibly sort of complex set of flows that often nobody really understands. So to map all the ways in which data moves across our National Health Service, you realise that there are literally thousands upon thousands of different individual flows that go from each of the GP's surgeries into centralised bits. Sometimes there are other local flows that not many people know about. If you sort of map the whole thing like an incredibly complex circuit board, and that's just the data, but you think about sort of financial flows, other sorts of flows of people and staff and so on. But is an incredibly complex set of interconnections which we often don't fully understand. Even the people who are experts in the system may not fully understand them. So I want next to make a distinction between two different sorts of optimization of a system. First, we can think of means optimization. This is a matter of kind of trying to work out, well, what are the flows that are in a system at the moment? How are they working? And then once you have a rough idea of how the flows are operating, there's a question, well, are there ways that these flows could be reconfigured to operate, to allow the system as a whole to operate better? Where by better we mean that it's somehow allow it to better either to instantiate or promote the values that we think that the system should be trying to operate. So that there's a variety of ways in which we can means optimize systems, so we can make the system run faster, make it do it more efficiently, be more resilient, create less errors, and so on. And we can also think of a different kind of optimization, which I want to call values optimization. That's when it is that we think about, well, what is it that this system is trying to do? In the case of a health system, it's like, well, what's the purpose of this health system? Is it to maximize health? Is it to reduce inequalities in health? Does it have a variety of goals? If so, are they intention? How do we specify them? So that in values optimization, we try to get clear about what our goals are. Now, again, philosophers don't usually put their cards on the table, but I suspect that most philosophers think that a lot of what they're interested in when it comes to health systems or health scarcities is the values optimization side rather than the means optimization side. And they tend to make various assumptions about value optimization. First of all, that philosophers tend to assume that our answer to what the best account of values optimization should be highly general. As it were, you work out what the values should be in the abstract, and then you apply them. You can apply that to a health system or to a variety of other sorts of systems. So that it might be general sort of utilitarian claim, well, the system should maximize well-being, or they're more sort of subtle answers that you can find in the competing claims literature, such as Alex Verhoeven's great article suggesting that in case of scarcity, you seek to meet the greatest sum of strength-weighted relevant claims. And another underlying assumption is the idea that values optimization is separable from means optimization, as it were, that philosophers often may admit that the means optimization stuff is going to be complicated, but it's not something we need to get our hands with as philosophers. That's somebody else's job. We can focus on the values optimization. I'm going to suggest that pretty much all of the elements of this picture are kind of pretty shaky or probably wrong if we look at how real-world health systems work. So first of all, I'm going to suggest that, well, it's really important to focus on flows as it were, the site of justice when it comes to scarcity. We need to understand what those flows are within the health system. And those are the things we need to be concentrated on. And also, what it is to optimize a health system, I think is highly specific to the fact that it is a health system. Whilst there's some generic things we can say about optimization, you need to take into account a specific set of values that come with healthcare and the assumptions that come with being a doctor, being a nurse. And that for these and a variety of other reasons, I think that when it comes to actually thinking hard about how to optimize health systems, we have to recognize that means optimization and values optimization, they're entangled, they're reciprocal. So basically, the net result is that in order to do this as philosophers, we do need to get our hands dirty. We do need to understand quite a lot more about the flows in particular health systems in order to help to optimize them. We can't, as it were, sit much further back and just abstractly talk about what the right values should be. So some of this analysis follows what we were talking about yesterday in the Rotman dialogue. So I argue in my book that if philosophy is going to be helpful for making wise decisions in the world, then somehow we need to pull off what I describe as a double process of translation. Somehow you need to take a sort of messy, complex, real-world context, sort of fill it out what the ethically relevant features are of it, then do the philosophy on the ethically relevant features of it, then translate back from this more simplified representation of a problem back into something which will be helpful for thinking about the real world. And I argue in the book that often we don't do that very well as philosophers. We may do the easy bit of saying, well, here's a simplified version of a problem, and then we sort of do sort of subtle work on the simplified version of the problem. But we don't do the hard yards of showing how to go from saying something interesting about the simplified problem back to say, well, here's what it means in this real-world context that we started from. And in fact, a lot of the philosophical writing about resource allocation, particularly stuff that's in the sort of, it's good philosophy in many ways, but the work in the competing claims literature, I think it's often not worked out in sufficient detail that you could actually use it to help make decisions in something as complex as your health system here or in our NHS in the UK. And so that for the rest of the paper, I'm going to talk a fair amount about cost-effectiveness analysis, because cost-effectiveness analysis at least is something where somebody's attempted to say, well, here's how we measure health. Here's actually how we do this job of constructing a model of how to measure health, how to weigh it, how to prioritize it, and use that as a way of making decisions. And I'm going to suggest that people who use cost-effectiveness analysis, and also people who are influenced by a lot of this sort of philosophical background idea that values optimization should be highly general, are going to need to make a number of assumptions which turn out to be quite dubious in real-world context. So, certainly cost-effectiveness, and I think often philosophers make these assumptions as well. So the first one would just be that, well, we can measure health, that we can measure it on a cardinal scale, so that across all health states, whether it's kind of spina bifida or the common cold or arthritis, we can measure health and we can compare it across health states using something like the quality adjusted life year. Second assumption is that those using cost-effectiveness analysis make is that, well, it makes sense to think that there's a single synoptic decision procedure, that somehow we can bring together all this information about the health effects of different treatments into a single decision procedure, which will allow us to make unambiguously fair choices. In the book, I sort of criticize both of those two assumptions. I suggest that, well, we can measure health, but there's a variety of different valid measures of health, and that we need to be more pluralistic, again, about when we're thinking about our decision procedures. Another assumption that philosophers and also those working in cost-effectiveness analysis tend to make is that measurements of cost-effectiveness have external validity. That's to say, we can measure how effective a particular intervention is in one context, and then we can use that information about how cost-effective it is in a variety of other contexts. Whereas I'm going to suggest, by looking at some real-world context, that in fact that's quite often not true. That even if you know how effective something is in an idealized context, once you plug it into a real-world health system with various different flows connected to it, then its cost-effectiveness may shift quite significantly. And the last assumption that is implicit within cost-effectiveness analysis in a lot of philosophical treatments is what I call static ranking. This is the idea that somehow we can keep everything fixed for the purpose of doing a resource allocation. That you know what the information is, and you can rank, for example, people's eligibility for a kidney transplant, or you can rank which drugs should go into a healthcare system, and that nothing's going to change unexpectedly over the period of us doing our resource allocation. Whereas I'm going to suggest, again, that static ranking turns out to be not true either in a lot of real-world contexts, and particularly in these cases of cascading scarcity, which I alluded to at the beginning. So for the rest of the talk, I want to talk a little bit about, well, how cost-effectiveness should work in theory, how it in fact sort of works in practice in our NHS, and then draw some sorts of lessons about, really, so, well, is it that we're not doing enough cost-effectiveness? Have we not gone in hard enough with our cost-effective analysis? Or are there certain sorts of limitations about measurement of health and optimization using cost-effectiveness analysis which we need to take account of? I'll suggest that there may be some inherent limits to the kind of approach do we see in cost-effectiveness analysis, so that we need a more flexible approach which will be grounded in a Deweyan sort of way of thinking about ethics. So one thing I find fascinating is if you look again in a lot of the literature in global health, and you see this particular diagram everywhere, and the World Health Organization designed it to help health systems think about sort of how they go from a situation that many sort of low-income health systems have, where that only a small percentage of the population has health coverage, and maybe not everything is covered. Maybe kidney transplant isn't covered. Maybe dialysis isn't covered. And also there's a question that often people may be having to pay more than they want to in co-payment. So there's a question about as you increase your healthcare budget, the thought is, well, we can expand the limits of this. Either there'd be trade-offs between, well, extending the coverage to people who aren't currently covered, to extending what sorts of treatments are available within the system, or reducing the co-payments that people have to make when they receive care. So I think it's a really helpful diagram for there. But one thing that's apparent, and I think it's gone wrong I think it's probably gone wrong in Ontario, it's certainly gone wrong in my own health system, is that in the UK we seem to have created a cube of healthcare entitlement, which actually turns out to be bigger than what the system in fact can deliver on the budget that it has. So we've almost got the reverse challenge to the WHO as conceived here. So that if you find that you have a problem in a healthcare system where the demand within your system systematically outstrips your capacity, then you have to do one of a number of things. Either you have to put more resources in, or there has to be some form of explicit rationing, so that you have to contract the scope of the coverage in one way. So either you say, well, people are going to need to make more co-payments, or maybe some more expensive cancer drugs won't be included anymore, for example. Or, there's some things that we can do with means optimization. We can redesign flows or throughput. Maybe we could make the hospital appointments a bit shorter, or maybe we can redesign the flows, maybe make things more efficient by 10 or 15%. But if we don't do any of these three things, then the problem is likely just to pile up. Maybe waiting lists will increase. And so what we're seeing in a lot of health systems that as they fail is what we can describe as implicit rationing. This can occur without anybody explicitly saying we're going to go for an approach of implicit rationing in our health system, so that queuing and congestion, just the unwanted net effect of excess demand within a system. So you can see it in the lunch canteen or a cafe, if suddenly 100 customers turn up and there's no seats for people have to wait outside. And interestingly, the health system where even though you do have various sort of explicit prioritization procedures, as we do in our NHS in the UK, if they don't do enough, then you're still going to end up with implicit rationing, even though you have some explicit prioritization processes. That seems to be what's happening in the NHS. So, next question is almost sort of, if cost-effectiveness analysis was everywhere in the health system, if it took cost-effectiveness completely seriously, how would it operate? How would it go about prioritizing? As a great health economist from York University, Anthony Cullier, has a kind of simple model he's a sort of a utilitarian's utilitarian when it comes to thinking about healthcare. He suggests that what the model should be that we would use is simple and 4 steps. First of all, we work out how cost-effective each intervention that we do in the health system is in terms of how many pounds per QALY does it cost. Then he says, well, what we then need to rank all the things that we could do in order of cost-effectiveness. So he asks us to imagine this as like putting books on a bookshelf. So you start with the highest books, and then you sort them down to the shortest book, where the height of the book represents how cost-effective the intervention is. And he suggests that what we then need to do is then to think about, the interventions that we can fund. He says, well, just start at the left-hand side and then gradually move right, so that, and then you just just move right until the budget runs out. So you always do the things that are most cost effective to do, and then after a point when the money runs out, say, well, sorry, the rest of these interventions are not cost effective enough to do. And then obviously if the budget then increases, then either either things more come into scope or go out of scope depending on the budget available. So that's a vision where he's calculated in such a way that if you actually did that, he thinks that you would actually maximize the health gain that you could get because you put all your money in the most cost-effective interventions. Now, one thing that's intriguing is that while our NHS in the UK makes a much greater use of cost-effectiveness analysis than most health systems, it's actually a very long way from actually anything like Collier's model. So I'll just give you three salient differences. So one point is within the NHS we have it, not all the interventions are tested for cost-effectiveness analysis in the first place. It's quite selective which ones are. The second, even when there is a test of cost-effectiveness, that NICE, the body which does it, it adopts a satisficing rather than a maximising approach. Rather it says, well, does something meet at least a certain sort of standard of cost-effectiveness? Does it create new QALYs for less than £30,000 per QALY? And in addition to that, there's no systematic attempt within the health system as a whole to try and work out what are the things we're doing at the moment that are of low cost effectiveness. So that between those things, there's no very great attempt to actually maximise the amount of QALYs we're producing in the health system at all. And that, in fact, when other health economists have looked in detail at how things actually operate in the English NHS, they discovered that a rather worrying thought that quite often when a new drug comes into the system, in fact, people's health gets worse overall. At least that's what they suggest the data tells us, because they said, well, if you crunch the data, and they reckon that the mean cost it takes to create a QALY within the NHS is around £13,000. But that NICE allows new drugs into the system where they cost up to £30,000 per QALY. And so that if you're introducing a lot of interventions which are less effective than your average and you're not increasing the budget, then presumably you're squeezing out interventions that would have been more effective. So I think this leads to a question for us. I mean, what should we do sort of once we begin to realise that, in fact, that the system we built in somewhere like the UK is quite a long way from Collier's model? I mean, one thing, I'm sure if Anthony Collier was here, he'd say, well, what we need to do is to double down. We need to just get much closer to my bookshelf model, to double down on cost-effectiveness analysis, and that'll maximise the amount of QALYs that we can produce. And, I mean, that's an answer, but I'm going to suggest that if we look a bit more closely at the way that sort of flows operate in healthcare systems, we can see that that's probably never going to be feasible. And we're going to realise that even where we do have accurate calculations of cost effectiveness in one context, we realise that they may not actually apply to other contexts, maybe depend a lot on the way that the flows are interconnected with our health system. And also, even when we come up with rankings on the basis of cost-effectiveness analysis, we may realise that those rankings, again, will not stay stable across different organisations of flows and different system capacity. So, as of mid-2022, or as of now, in fact, NHS in the UK faces worse waiting lists than at any time in its history. That about 6.5 million people on a hospital waiting list out of the UK, out of a population of 65 million or so, and it's continuing to rise. And it's not just, as it were, waiting lists for routine operations. You look at a whole range of indicators, things like ambulance waiting times, how long it takes for people to get seen in an emergency department. All the lights are blinking red on the system. If the system had a dashboard, then all the lights would be on red. Now, there's a question about why does waiting time matter? I mean, although there's not much been written philosophically about the idea of first come, first served. In fact, we were discussing this a little bit over lunch, as whether it was fair that the people who arrived earlier should have more pizza than the people who got there later. But that within sort of the rest of life, and often sort of first come, first served. It's used as a sort of de facto sort of system that people think is fair enough. So you think about, you go to the grocery store or something, they're waiting in line, people assume that's sort of reasonably fair. So the question, well, is it a fair way of allocating healthcare resources? And I think there's sort of two kind of important and obvious problems with first come, first served as an approach in healthcare. The first one is it's people whose healthcare needs arise earlier don't thereby have needs that are either more urgent or more important. If you think about how crazy it would be to run a hospital emergency department on a strict first come, first served basis, somebody comes in with, I don't know, they've hurt their toe, think, well, we've got to see this person before the person who comes afterwards who has a heart attack. That would be crazy. So first come, first served, not a good way of distributing according to need. And the second problem is that in lots of cases, maybe in the majority of cases, patients' healthcare needs themselves change over time. Some cases will end up being self-limiting. Somebody may get better within a few days, as in a common cold. In other cases, the problem will exacerbate over time if we don't do anything about it. And I think that ought to make a difference to the way we think about allocating resources. So if you're using sort of implicit rationing, or basically allowing waiting lists to grow, that's your way of de facto way of allocating resources. And also demand is systematically outstripping capacity within your system, then the obvious implication is that waiting times are going to grow longer over time. But that if demand outstrips capacity and patients' conditions also worsen over time, then I think that first come, first served is just a perverse approach to take to prioritising our scarce resources. The problem is that patients will never reach the front of the queue until they're already pretty sick. I'll tell you this story. I call this the parable of the stale bread, because my parents-in-law they think they have the moral duty to finish up food, and so that if you go around their house and you buy a fresh loaf of bread, they say, "Oh, we shouldn't eat the fresh loaf of bread. We should finish up the old bread first," which has the perverse implication that you never get to eat the fresh bread because it's always gone stale by the time you got to it. Which obviously matters a little bit in food, but if that's what your health system is doing, it's a huge problem. So I think one implication of this is that a fair allocation system shouldn't assume this idea of static ranking. It needs to keep track of the effects that waiting has on people's healthcare need and whether they're exacerbated as they come to wait longer. So I think cataract surgery is a decent example of this. So I picked cataract surgery just because it's such a sort of common and routine operation. Sort of all healthcare systems do a lot of cataract operations. In the NHS in the UK, the target for all non-urgent operations is 18 weeks. Now, that wasn't being met before the pandemic, but since then things got an awful lot worse. So that the waiting times increased by 35% in 2019 to 20, another 36% last year. And I haven't got the figures for this year yet, but I could bet you a lot of money that they continue to get worse. So the implication was in 2021, the average wait time was 40 weeks when the target was 18 weeks. And that's a mean, so there are lots of places in the country where it's even worse than that. And so cataracts, it's a progressive condition, so that the longer you leave it before the operation, the greater the complexity of the operation, also the greater the likelihood of complications. And so that one implication is that cataract cases take longer to treat and more prone to complications as the cataracts worsen, and the cataracts worsen as patients wait longer for treatment. And so that making people wait longer for cataract treatment is not only sort of a cost ineffective, but also clearly it's unethical if you know that people are going to deteriorate before they get to the front of the queue. But the challenge is that given that, as it were, that the cases get much more complex as people have to wait longer, it's actually much, much more difficult to reduce a significant backlog than it is to keep a system ticking over when you have shorter waiting times. Now, that's just the tip of the iceberg, because think about all the other sorts of flows within a health system. So I think that cataracts is one case, but there's lots of structurally similar problems, and that in order for a modern healthcare system to work properly, patients' resources need to flow across institutional boundaries kind of freely and seamlessly. Insofar as there's sort of blockages to that, then a lot of things are going to back up and you're going to see a lot of unnecessary harm. You may see these cascading scarcities. So there's an old parable just called "For the Want of a Nail," if you may remember it. For the want of a nail, the horseshoe is lost. For the want of the horseshoe, the horse is lost. For the want of the horse, the rider is lost. Then it turns out the battle is lost and the kingdom is lost just for the want of a nail. It's just got a really sort of early example of the idea of a cascading scarcity. And I mean, one thing that's tricky and really kind of depressing when you sort of read about it and think about it, that we're seeing those sort of cascading scarcities in a lot of health systems at the moment. So here's just one of them, one of the most salient ones, so that you can't discharge patients from hospital unless there's somewhere safe for them to go, somewhere with sufficient resources to go for them to be either cared at home or in some kind of sheltered accommodation. So in many health systems, you have a variety, a number of people who are well enough to be discharged from hospital but can't be discharged from hospital. But that to the extent you have people in your hospital who are well enough to be discharged but can't be, that means that it's much more difficult to move patients around in hospital, so that you may find that it's more difficult to move people out of your emergency department onto the wards because there isn't the space on the wards. But that if you can't move people out of your emergency department because there's no beds for them, then those beds in your emergency department are still being taken up, and you can't then move more people into the emergency department so that patients end up waiting in ambulances in hospital car parks. And that again has knock-on effects. It means that the ambulance response times are much worse, because if the ambulance people have to be still waiting with the patients, they can't be going out helping other people. It leads to greater stress and a lot of later call volume for the people who do the emergency calls. So basically people ring up to shout, well, my father's had a stroke, where's the ambulance? So that, certainly just as a result of this greater wait time, call volumes went up about 40%, I think, in the UK as a result of failures in ambulance waiting time. And so it's this kind of problem I'm really interested in. I think if you talk to anyone who works in a health system, it's an incredibly salient problem, but it's not a problem that philosophers have really sort of thought about or attempted to theorize before. I think it's partly because it's a problem that only arises in context, and only when you understand the way that the different flows interrelate, you can even begin to see what the problem is, let alone begin to theorize it. So the rest of the paper is me attempting to sort of make some initial moves towards thinking about, how we should think about these kinds of problems philosophically. In particular, how we should think about means optimization, given that we've seen in these sorts of cases probably just saying what we need to do is more cost-effectiveness analysis isn't going to wash. So we've seen that in these cases of cascading scarcity, neither external validity nor static ranking seems to hold reliably. So it doesn't look like a sort of case where we say, well, all we need to do is to work out what the right ethical theory is or what the right account of the values is, and we can just apply it. We need to sort of think much harder about what the relationship is between values optimization and means optimization. And I think we're going to see as a result of that, in these real-world health system cases, the values optimization and means optimization they're just sort of entangled with one another. We don't sort of improve the quality of analysis by trying to pull them apart too far. And so what a lot of work will require is almost sort of understanding in more detail what the flows are, the ways in which particular flows within health systems are either helping patients or harming them, redistributing risks and so on. So think about how to map those flows, and are there ways of remapping them that would be ethically better. Now, a couple of words almost about what does it mean to think of means optimization and values optimization as more closely entwined. So a lot of what I say here is basically sort of an application of some of John Dewey's thoughts. He has a great late book, The Theory of Valuation, I published in 1939, where he says some quite similar things to this. And he points out there's always a continuum between means and ends. So, I mean, first thing to say is that, well, there's an obvious sort of relativity of means optimization to values optimization. So that insofar as we change what we think the goals of our health system are, or what it would be for it to be a good health system, that also shifts your understanding of what would be a good means optimization. If we have a thought that, well, if we suddenly realize post-COVID that resilience is much more important than we thought it is in a health system, then that means that, well, if we're means optimizing our system so that it's better at attaining those ends, we may think, well, in fact, yeah, we need more redundancy in our beds. We need more spare capacity in our health system than we previously thought. But I think it's also the case that when we're trying to develop an account of values optimization, we need to take means optimization into account as well. So that, I mean, often when we sort of optimize our means better, we see possibilities that we hadn't seen before. So it allows us to better specify and reconcile the values that we have. So that in a lot of the work I'm doing on NHS data, we've built a new system called a secure data environment, which allows, as it were, data to be held centrally and doesn't need to move around. There's not going to be sort of hundreds of organisations that have copies of all the patients' data. There's only going to be one central place. That data is never going to go anywhere. People will be able to run queries against that data and then receive results against it. So you've massively reduced a lot of the privacy worries which previously existed. And given that you've reduced those privacy worries, it then allows you to reconfigure some of the ways that you allow access to the data without sort of violating other sorts of ethical principles. So you allow yourself to do more and to achieve system goals in a new way which wasn't possible before. That often happens as a result of us sort of changing processes and improving them. But it can also happen that, if we try very hard to achieve a particular goal, then it turns out that maybe it's much more expensive than we thought, or what we do is much more error-prone, or it has side effects that we hadn't anticipated. Then we may realise that, well, maybe it wasn't such a good system goal overall. Maybe we need to do further values optimization. It might turn out they think, well, yeah, on paper that was a good goal, but in practice it turned out to be not such a good one overall. So it may be that, as it were, sort of trying to do the means optimization suggests that we need to rethink what our values are. Now, as I mentioned before, the idea of means optimization can be quite generic in one sense that, well, whether you're running a factory or a farm or a football team, you can engage in means optimization. So one of the things I'd sort of like to think through with you is almost think, well, what are the features of healthcare systems that make sort of means optimization within health systems unique or sui generis? I mean, one thing I think is important to realize about means optimization is that I take it to be a lot of the time just an everyday activity rather than something which is only done by special people under special circumstances. So that just a lot of what goes on every day, and whether in a hospital or even a university, if you think about, if you teach every year, you get your student evaluations. You think about, how could I do that session better? I understand, or you read the essays and you realise, I thought I'd explained that clearly, but I hadn't. So that you realise that you're engaged in a process of kind of optimising what you're doing. It's nothing about cost effectiveness, but rather you're engaged in a kind of dialogue about, well, how can I achieve the goals that I was trying to achieve, better than I did last year. And again, similar things happening in hospitals all the time. People thinking about, well, how do we redesign our processes? Or you may have a problem that last year you realised you allowed too many people to go on holiday at the same time, which meant that you were short-staffed. Think, well, how do we redesign a rota? That's, again, it's a form of means optimization, nothing to do with cost-effectiveness analysis. So I think cost-effectiveness analysis is a means of means optimization, but it's not the only one. And in fact, I think it's a relatively unusual means of means optimization. So that in cost-effectiveness analysis, what you do is you say, well, there's one measure for everything in a system. You measure all the component parts of a system against the same set of value and the same standards of efficiency. That's kind of the exception rather than the rule. A lot of the time you look at industrial processes where, again, you're continually trying to means optimize things. Think about how an iPhone has improved from iPhone 1 to 2 to 3 to 5 to 7 to 14 now. That, as it were, a lot of the time you're thinking about the individual components. I think, well, how can we increase that, the sort of shatterproofness of the screen or the smoothness of that bit of the operating system? That a lot of the time you're thinking about, well, how did that component work before? How can we improve that component so that it allows that the system as a whole to work better? And so I take it that, in fact, that in health systems that there's a variety of different sorts of means optimization are already going on. Anyway, and it's sort of, in a way, it comes with the territory that people take pride in their work. They'll try to do it better, and so that that's a way of sort of reframing almost what's going on, where you realise that means optimization is always going on, and there may be some sort of external forms of means optimization. Say, well, what we need to do is to bring in somebody to measure all this, and then on basis of that provide us with an additional set of priorities and rankings, and that might well improve things, but it might not. And so that maybe the wisdom will be to think through, well, when are our existing processes of quality improvement sufficient? When it's a system actually really properly helped by doing the kind of measurement involved in something like a cost-effectiveness analysis. And one of the, I think, interesting and distressing features of healthcare over the last few years is just the sheer number of nurses and doctors, clinicians who've decided to leave, basically given up. Either they've taken early retirement, they've moved country, or just left the system altogether. And I think reflecting on some of the reasons for that requires us to think about almost what we mean by means optimization. What does something like maximum efficiency mean in the context of a system? Because when we're means optimizing some elements, you might think, well, some elements are just replaceable, so that if you have an office photocopier, you might know that, well, it's supposed to be sort of certified to do maybe 5,000 copies a month. You might, well, this month we've got a lot more to do. Let's do 15,000 copies. You might do that in the full awareness that it's more likely to break down. You might need to call the engineer or maybe even get a new photocopier, but think, well, it's just a photocopier. No particular ethical issues arise with doing that with a photocopy. But obviously, to state the obvious, human beings are not photocopiers. We're not replaceable. And that a health system cannot and should not, as it were, attempt to sort of price in the cost of staff moral injury and a breakdown, to think, well, this is just the most efficient way of doing it. So that almost to think through what it is to means optimize a health system, well, where the major moving parts within the health system, the major sort of expenses within a health system, the major things that make a difference between a good and a bad health system are the workers themselves. It requires us to reflect on some of the moral boundaries and the kind of respect that's necessary to work with people to improve the standard of care that they can provide. And I think one way of doing this, which I find quite helpful, is to think of healthcare as a practice in Alistair McIntyre's sense. So he suggests that what a practice is a socially established cooperative human activity through which those people in the practice aim to achieve standards of excellence. And his idea is that the achievement of these standards of excellence partly determines the shape of this activity. So that if you think of healthcare as a practice, then clearly it's, well, there may be other goals to it as well. Centrally, it's focused on the restoration of health, relief of suffering, and so on. And those values go deep with people who are doctors and nurses and other sort of allied health professionals. And you can't, as it were, sort of ignore or sideline those values in thinking about what it would be to means optimize a health system. As it were, just because if you means optimize a health system in a way that sort of ends up stepping on those values or undermining them, it's not a very good means optimization, because if you've undermined the values that you're trying to serve, you've made things worse rather than better. And here we come back to the idea of prioritization. And I think that one of the things that makes it difficult in the full context of healthcare is that, well, we noted from the beginning this sort of the ubiquity of scarcity within healthcare, so that even the most basic things, as it were, that you have a limited number of doctors, a limited number of patients, and that any time given to one patient in providing care for them is time that can't be given to another one. So that care must, by its nature, be limited. But limiting care comes into a significant degree of tension with the responsiveness to human need and suffering that seems to be at the ethical core of healthcare. And so I think one of the things that's led to so many people suffering kind of burnout or leaving healthcare is that it's just going to be quite morally distressing for clinicians to have to practice in a way that doesn't allow them to provide what they take to be good enough care for their patients. So I'm going to sort of give this as a case for you. Well, we could think of it as a thought experiment, but I think it's a sort of a real-world thing that happens in healthcare in many health systems all the time. So call this the cost saving as a case. A process of means optimization increases the cost-effectiveness of care on a ward by increasing the number of patients for which each clinician has responsibility. These reforms also make it more difficult for clinicians to establish a personal relationship with patients and somewhat increase workplace stress. It's known that the conscientious clinicians may respond to such pressures by attempting to maintain quality of care through creeping increases of unpaid overtime. Is this policy unethical? And one question we might want to think through in deciding whether we think that's ethically acceptable or not is, well, what's going to happen to the money from the cost saves? Are we going to reinvest it in improving care for other patients? You might think that, well, if it allows overall better care for patients, then maybe it's something we should accept. But it seems like it's a matter for reasonable disagreement, and it may be that different health systems will decide the answer to that in different ways. So we've covered quite a lot of topics in this talk. I mean, the most important point I've attempted to make was to point to a set of problems which I think are really, really important for health systems as we find them, but which have not been very much theorized by philosophers before. These are problems of cascading, scarcity. And we've seen that in these kind of cases, we can't assume that any kind of measure of cost effectiveness will have external validity, nor can we assume that kind of rankings and prioritizations will remain static. We'll see that conditions will exacerbate over time, for example. And I've also suggested that when we're thinking about sort of cases of this sort with interconnected flows, our best conception of optimization for a health system is going to need to be one in which sees means optimization and values optimization as entangled and reciprocal. It's also going to be one where our account of means optimization is somewhat sui generis for healthcare. It takes into account those sort of what McIntyre would call the goods internal to the practice of healthcare. So to make progress will really require us to do some of the detailed work of sort of looking at the particular kind of flows and the ways that individual patients are actually either made worse or improved by those flows. What can we do about them? What are the unfairnesses that arise in particular contexts, in particular health systems at a particular time? And I think that that's all the work of philosophy, that our work isn't done when we've sort of thought about values optimization in a very abstract sense. That I think that all this work of thinking about flows in health systems is part of philosophy, and I guess I encourage you to help me think about it. So thank you. I think I probably can. Right? Well, yeah.
Yeah, thanks. It was a really terrific talk. So the question I have is something that's slightly orthogonal, which is that in any system optimization problem, you'd have some specification of what are the normal circumstances under which the system operates. And so you might ask, so the question is, are there sort of similar questions about values and means that come in when you try to ask, under what scope of variations should we be considering the optimization? Do we want to say, in civil engineering, it's often like, in a 100-year flood, is it supposed to still function okay? And so in the case of the health systems, we've just gone through, hopefully once in a century event. So I think you can see the question is, how do we think about the scope of variation that we...
Yeah. No, I think it's a great question. I mean, to me it seems obvious that most health systems hadn't thought hard enough that question before, that they hadn't really done the equivalent of planning for a 100-year flood. In a lot of cases, things just kind of fell over, or it realized that, well, that almost sort of like numbers of hospital beds per person. You saw that if you looked across, a lot of the measures, it turned out those vary quite widely between a country like Germany had about 2.5 times as many hospital beds per person in the UK, and that sort of allowed them, that greater capacity allowed them to do a lot more flexibility in dealing with it. So that I think clearly we saw that variation in practice, and I think that it wasn't. I don't think it was the case that most health systems had really sort of thought about this systematically in terms of resilience. I think, well, how big a shock do we need to be able to absorb? And I think it's a question that all health systems need to be able to think through. I mean, I think one of the things that's really tricky about it is the problem of spare capacity, because clearly the more kind of spare capacity, the more sort of resilience you build in, the more expensive it is for the rest of the time. And I think that while the memory is fresh, it's sort of easier to commit that money, whereas it's sort of, I think that one of the big challenges a lot of systems had with their pandemic planning is that even when people had plans or they knew their things were supposed to be done, then it was difficult to get the money, the resources, and the money. So that, I mean, I think it would be sensible to do the equivalent of how resilient are we against the 100-year threat, and then at least sort of have an account of that, and then explicitly debate it. I'm not sure that I don't have an answer as to whether should you be able to be resilient to the 1 in 100 year or 1 in 1,000 year and the 1 in 50 year. But I think it's an important question. In a way, I think you have to decide it by democratic deliberation, because one of the hard questions in these sort of cases that you realise that, well, if you have a sort of limited amount, if politicians may sort of genuinely and I guess sincerely believe that, well, we're sort of more at the limit that we can ask people to pay in tax, we make people either going to revolt or whatever. And you think, well, if we can take maybe sort of 10% of GDP and put it towards health and healthcare, how do we best spend that? And that there may be, that increasing resilience may come at the ability to improve care or provide sort of access to the best drugs. And so, yeah, I have a feeling that it's going to get quite kind of specific, and there may be sort of reasonable differences of opinion that will come out in different countries as they, even amongst people who've got all the data in front of them and are thinking hard about it. Yeah.
So you said that means optimization is sometimes not related to cost effectiveness, and as like a daily activity, cost effectiveness is not going to drive means optimization all the time. And I'm wondering if you could tell a little bit more about that, because what do you mean by cost effectiveness, and couldn't we have in that concept more like a more pluralistic view, human view, or values that are included in that, so that we could say that it always kind of drives means optimization, but in different ways? Like, I'm not sure why it doesn't drive means optimization all the time.
Yeah, I mean, within healthcare, cost effectiveness analysis has a slightly more specific meaning, where usually you have a sense of, well, what's the amount of some goal or output you can achieve for a particular amount of money. And if you can measure everything in terms of, say, quality adjusted life years, it allows you to measure everything on the same basis and then sort of rank in that way. And so that one of my arguments was that you don't need to measure everything with the same stick in order to do useful optimization. And what you're suggesting to me is that, well, can we be more pluralistic in the way we measure what counts as an improvement? And I think I would say yes, and indeed that we should be. But one of the challenges is that if you go for a sort of a pluralism of measures, then you then have a set of questions about almost how do we go about doing the prioritization then? If it turns out if you have sort of maybe 4 or 5 or 10 different measuring sticks, and that all of the measuring sticks apply to different things, then there's a question about, if you then face this question about which of these improvements is most important to achieve, then you don't have an obvious answer to that. And one of the benefits and one of the reasons why people like cost-effectiveness analysis or they like cost-benefit analysis is that it gives the appearance of an answer to those sorts of questions, where you're able to put everything on the same page, use the same units, and then rank them on that basis. And so basically, I agree that we can and we should be more pluralistic in our approach to measure. I think there can be different ways of validly measuring benefit, but as soon as you do that, then you realise you need a more sophisticated discussion about what do you do with the results of your measurements. In that case, if you have incommensurable measurements, then it becomes much more complex to decide how to use them in a process of prioritization. Yeah.
I was kind of hoping that philosophy would help people to explicate their values to manage that multidimensional measurement problem. I think that's kind of what I was hoping. I was hoping you guys have an answer for that. Not really, but so if I could, I'd like to advocate on behalf of primary care and family medicine, and we'll get fact-checked by our actual family medicine person at the back. But so you led with qualities, and I appreciate why that's a very important and salient example. Family medicine and primary care as an academic discipline has really been one of the leaders of thinking about values in a multidimensional way in health care. And if you talk to an academic family physician and you ask them about what matters in a health system, I'm going to say a large fraction are going to mention something like the quadruple aim or the quintuple aim. Do these phrases mean anything to you? Or have you heard them before?
Yeah.
And so they are not operationalized, but they identify improving the patient and caregiver experience as one dimension that matters, improving the health of populations, which is interesting, that matters, reducing per capita costs, improving the work life of providers, and equity is the new quintuple aim, which was just written about kind of earlier this year. And so that discipline has recognized for a long time that value in health is multidimensional. They've been talking about it for 25 years or more. And I think that a lot of the things that you're discussing here, while they're important and people use them all the time, as you say, have a certain centering in tertiary care and health economics and policy. And the scope, if it were broadened to include some of these other ideas that people have been talking about for a long time, might be fruitful to kind of have an exchange between these ideas where people, and I love that I'm sorry, I forget exactly what you said, like, you give the impression that these qualities are all on the same, that they're all comparable. But depending on the health economist that you talk to, and I'm sure you know this, some of them are totally willing to compare a diabetes quality against a blindness quality. And other ones are like, oh my God, no, absolutely not. Right? There's not consensus at all that you could compare some kinds of qualities with other kinds of qualities. And if you guys knew how qualities were generated, a lot of you would be horrified. Like, the sorts of questions that are used to elicit qualities from people are about things that are very hypothetical, and they're asked to make a decision on it. So anyway, so I just wanted to bring that up because I think that this quintuple aim plays a key role in the thought in academic, like I say, family medicine, primary care, and it certainly rubs up against this in some way. I'm not sure how, and I don't know the best way to think about it, but I do think it matters.
Yeah. No, I think you're right about that. And one thing that's weird about that literature on sort of quality within healthcare is it's been largely ignored by philosophers. I mean, in the UK, there's a sort of quite important project being led by Alan Cribb and Vicky Entwistle, and one of my Polly Mitchell, who did a PhD with me a few years ago, was also a researcher on that. And they've been almost sort of doing almost the philosophy of quality, if you like, trying to work out, sort of reconcile almost sort of how to interpret quality, how to determine which things should be a dimension of quality. What the relationship is between healthcare outcomes and quality. If, for example, a member of staff is kind of rude to you or misgenders a patient, does that count as a harm? Is that a healthcare harm? Is that merely somebody being rude to them? Is it reduction in equality? There's quite a sort of complex set of philosophical and ethical questions which are, in many ways, have not been sort of explored that much within that literature. I have no idea why it is that philosophers and ethicists have not really got involved in that literature. In something like the Journal of Medical Ethics, is going for 40 years. The leading, it's only in the last 2 or 3 years that people have started writing sort of articles on these ideas of quality. So I'm not really quite sure about that. And I've read some of that literature, but I suspect not enough of it. And so that in many ways, I think it would be a good thing if almost one of the conclusions of this paper is if people say, if get to the point where sort of, well, I'm able to translate some of those ideas into a medium that philosophers are able to engage with, and then people are able to say, over here people have been talking about that for 20 or 30 years, and then there's a lot of stuff that philosophers could draw on and engage with.
Huge contributions, because like I say, they're not operationalized, right? And so, and obviously that's what the hard part is. And I think that work in philosophy on helping to operationalize both what does each of those aims mean, and is how should we think about making these kinds of I think it just would be hugely valuable. Can I have and another thing?
Yeah, of course.
And another thing. The other thing, another really important idea that's emerged in family medicine is the idea of patient-centered care, which is in opposition to disease-centered care. And quality is about a disease. Health is about so much more than a disease, and it's about so much more than health care, that there's an implicit, when you go to qualities, you go away from patient-centered care, just by virtue of choosing to use those as your metric, potentially. So I think that there's also some ideas that are taken for granted in this health econ setting, that in family medicine, very different formulations of how we should be thinking about what it means for a patient to be successful. And I think that there could be some interesting cross-pollination there as well.
I think I basically agree with you on that. I mean, I think to be fair to qualies, they're grounded in the 5 dimensions of things that do matter to people. It's about, well, sort of, can you sort of care for yourself? Are you in pain? The sort of questions they ask, I think they're general enough that it would be weird as an individual to not care about, for instance, whether you're in pain or whether you're able to do your usual activities. So, I mean, to that extent, well, in one sense, it's disease-centered, but in another sense, they tend to abstract from that and think about the quality of life implications of different diseases and to focus on the quality of life implications.
No, I totally agree with that, and you're right, that they kind of belong to the family of what people call patient-reported outcomes.
Yeah.
I totally agree that that's a positive. Yeah.
Okay.
Yeah. Thanks.
Yeah.
Your comment that implicit rationing results in queuing and congestion is well taken, but I think that there's a third dimension. There are unmet health needs that go entirely unmet. And your cataract patient is still going to make it to the front of the queue. They're still going to get their cataract procedure performed. Your cancer patient may end up passing away before they ever receive care. And my particular area of interest in terms of research is rural healthcare, where if you don't have a practitioner in that environment, the barrier to accessing care may be so great that you're not even captured in any of these metrics because your need has never been presented to the healthcare system to even get in the queue to then be able to wait to get to the front of the line. So if anything, I think you've captured so much of my experience beautifully, but that particular aspect is probably understating the problem.
Yeah, can I just agree with you and say thank you? Yeah, I guess I'm almost sort of trying to work out how what we do about that kind of unmet need, which is not even noticed. Maybe we just have some ways of estimating it, but that the difficulty of when you don't have enough of physicians in an area, or people for one reason or don't go to the physician, where if there's a lot of suffering that you just are unaware of, that seems to be a huge problem. Yeah.
So this actually has to do with the static rankings as well. One of the takeaways was that they don't hold reliably, right? And that we need to be thinking about them more dynamically. And so I'm wondering, are the 2 examples you chose, I see how they're not static, right? So you gave us the stale bread and you gave us the cataract example. But both of these don't seem to do the work that you need it to do, in that the dynamics are very predictable, and that you, like the cataract case, you said, the longer you wait, the worse it is. So the alternatives to this sort of static ranking, like even if we know the dynamics, we would still, like the alternative is to eat the fresh bread now and then throw out the moldy bread later, right? Do you see how in these cases it doesn't seem like it's not because the dynamics are so predictable, and because once we have this line, it's going to progress in a particular predictable way, it doesn't seem to really motivate the need to move to a dynamic ranking, right? It doesn't show us another way to organize those individuals, right? The ones who are queuing for cataract surgery or fresh bread.
Yeah. I think, well, the example should at least show that there's a problem with, as it were, asking people to queue up for it if you know that the queue is going to continue to get longer. So that I hope that the example still does that. Certainly I hadn't offered an alternative approach to kind of ranking in those kinds of cases. And certainly I think one alternative you might have is almost to sort of to be able to sort of monitor people more closely to understand are there different rates of deterioration in different patients, and so think, well, insofar as somebody's condition is deteriorating more quickly, that would be a factor which placed them at higher priority to make the system of allocation more dynamic in that way, where you're trying to work out almost sort of either sort of maximizing against the goal, or at least trying to ensure that nobody gets worse than a certain point before they're operating. And if people are sort of deteriorating at different levels, that might bring a greater sort of dynamic nature to it. So, yeah, is that an answer to you, or is it still sort of a bit inadequate?
No, I mean that is what I expected you to show us.
Yeah.
Examples where the dynamics were less predictable and rates would change, and which would cause a reordering, right? Which is what you're now suggesting. If somehow we can track the rates and the rates aren't all the same, then the queue would need to be reordered if we're still using a queue-based system.
Yeah, but certainly that's often the way that, for example, sort of organ transplant queues will work. That sort of if somebody condition sort of deteriorates massively, or somebody has an urgent need, then they may be bumped up a queue just because, even if they've been waiting less long, just because if they don't get the transplantation very soon, then they'll die. And that, I think in those kind of cases, I do support the dynamic ranking. Often what's actually used in practice within health systems, as well as sort of obviously sort of tissue matching and other sorts of things. So I think it can be done. It's quite sort of complex, and often it requires knowing a fair amount about individual patients. But I think that sort of certainly there's strong reasons for thinking that if you have the data for that, it's fairer to do it that way than to just have a straightforward queue, just because for all the reasons we've seen, that, as it were, that a straightforward sort of waiting in line queue, it's not a very good way of allocating care on the basis of need. Yeah, I think Max afterwards. Yeah, Varun.
Thank you for the talk. Just a quick question. Could you say a few more words about what's the advantage of choosing a systems approach to healthcare? Because one apparent advantage is you can capture the complexity of the system. There are a lot of flows. I mean, just thinking like a box, there's input, there's output, there's a lot of flows, and you're asking practitioners to look at the philosophers to look at the flows. But one apparent disadvantage is that when you conceive of a system, is it an open system? Is it a closed system? Because when you treat healthcare as an open system, there are other systems, the economic system, the education system, and all these factors kind of this entanglement between all these systems. So how do you then, what considerations going to choose what constricts the space of choice? How do you choose the system, etc., etc.? Can you just say a few more words about
Yeah, of course. I think that, well, back to some of the things we were talking about yesterday in the Rotman dialogue, where it seems that all models are going to be wrong. All models will have limitations. And so I think that in many cases, there's a question about how much computing power do we have, how much data do we have available, which sorts of flows is it helpful to be able to map. And so I think that, that for anyone who's sort of working in a particular hospital or a health system, often just from the way that your job works, you have a kind of sense of which flows matter over time, and that often you may have a strong sense that, well, there's problems with a handoff between the hospital and social care services, and you may have a lot of these sorts of cases where you realise that somebody's well enough to discharge, but there's nowhere for them to go to in the community. In those sort of cases, you realise that, well, you might have strong reasons for thinking that, well, if we have a model which is looking at flows within the hospital, then we aren't thinking hard enough about what happens outside. And so that a lot of the time it would just be sort of pragmatic where you draw the boundaries of there. There's no sort of, I think you're right that in a way that sort of the system's view is that everything is connected to everything else, apart from, it's not helpful in practice to kind of try and sort of, well, to explicitly visualize every single interconnection. Your brain would just explode. I mean, Borges has a famous short story which I talk about in the book about an emperor who wants a map of his empire, and they build this massive map of it. So it's not big enough. Make me a map which was the size of the whole empire, and then they do it, and it turns out to be it's absolutely useless as a map because it's just so big that nobody can use it. It's the same as the territory, and you realise that, well, sort of what we want from system maps is a way of organising and simplifying a degree of complexity in order to help us to make decisions, but that we always have to be aware that in doing that we focus on some flows rather than others, and there'll be things that are causally relevant or normatively relevant that we haven't fully accounted for. And so in a way that just requires a degree of humility and a realization that you may be wrong. You maybe need to come back to your assumptions, and that if there are things that you realize turned out to be relevant that you hadn't sort of mapped before, you need to go ahead and map those.
I'm glad you went first because my question follows on. Thanks very much, James. You've written a lot about something which didn't, I don't think, explicitly figure into the presentation of the paper, which is the social determinants of health. And it seems to me that, taking seriously the social determinants of health as an input to the system might militate in terms of means optimization, directing funds out of the healthcare system. So I'm just wondering your thoughts on how that figures into this thinking.
I think it's an excellent question, and I think you're right on all fronts. This paper is I think it's maybe more written for an audience of sort of health economists or people who are sort of interested in the kind of problem that NICE sets itself in the UK, to think about where people think that, well, almost that we're almost there with cost effectiveness if only we do a bit more of it. And then to be able to show some sort of problems inherent in that, and when you sort of look at the way that health systems operate. And so that, yes, I think that I would completely agree that, yeah, in some ways my book is sort of about kind of how to bring together means optimization and values optimization for a health system as a whole. And I think I completely agree that that a lot more attention to the social determinants of health would usually be very helpful, just because, well, very often, well, there's obviously reasons why very often prevention is better than cure. In addition to that, you can just be more effective if you intervene downstream. So that, yes, certainly if you're sort of doing the best approach to optimization of a health system is one that will take into account the social determinants of health. I think maybe one of the reasons I didn't talk about that today is that I thought, once there's enough going on in this paper as it was, I thought to add that would be a further layer of complexity. So I was trying to keep things sort of manageably simple. So basically, I agree with you.
Yeah, I mean, my question might sound silly, but you talked earlier on about like the model building and all models are wrong and so on. And I wonder whether one of the conclusions that we can draw from your observations about difficulties with cost-benefit analysis is that it's not just the models that are wrong, it's that the whole framework of thinking in terms of cost-benefit analysis is wrong. But we need to get out of that. I don't know what the alternative might be. And background in biology leads me to thinking in terms of adaptation instead of optimization, where things are effective but not always efficient, right? So they work. Progress is only understood in terms of getting out of the rut instead of trying to reach the top, right?
Yeah.
So I don't know whether it makes sense even to introduce these kind of concepts in this context, or yeah, an economist would probably throw rocks at me right now.
Yeah. But no, I think it's a really good question. I think that there are some cases where cost effectiveness analysis or some kind of common measure turns out to be really useful. I mean, there's I guess it's a slightly niche interest book. It's a very interesting book just called Glaziers and Window Breakers, which was published in the UK, where the person who wrote it sort of interviewed every single Minister for Health that we'd have over about sort of 40 or 50 years, all the ones who are still alive. And the person who was Margaret Thatcher's first health minister, he said that, well, one of the things that when I became health minister in 1979, he said nobody knew how much a procedure cost, so that if you wanted to find out, would it be, if there are different ways of performing a procedure, nobody was able to put a cost on that and work out whether you could save money doing that. And I think that is a really weird position to be in a health system, and that we do know that there's sort of obvious sort of quick wins. If you think of shifting out from using kind of branded drugs to generics, where it's basically the same drug, but just the branded drug is usually a fair amount more expensive. In those kinds of cases, it seems such an obvious quick win, and you realise you're sort of throwing the money away if you're buying the much more expensive drug. So there are a number of cases where you realise that it's useful to at least have some kind of measurement which we can apply, which will allow us to compare things at a broad level, to just think, effectively to ask on behalf of the public, are we getting good value for money here? And I think so. Some kind of measure using something like the QALY is kind of useful at a high level, just to be able to answer that sort of level at a quite sort of coarse level. I think that insofar as you try to use it to drive everything in a health system, I think I agree with you that we had the questions about, well, do we agree with the underlying value framework? I've given a few reasons in the talk to say, well, maybe we shouldn't, but there's obviously other reasons that you might, if you're a non-consequentialist, you might think the whole thing is a bit bogus, but that nonetheless you might think that there's often going to be a use for some kind of external measuring stick, even if you think it's a somewhat inadequate measuring stick, or one that's kind of flawed in various ways, just because as we're having no way of having had a health system where there was no way of comparing kind of things, say sort of hip replacements to cancer therapy, you had no way of making any kind of judgments about which one's a better use of public money. You'd be in a much worse position, I think.
Okay, thanks so much everybody for coming, and thanks so much James for teaching us about what makes a health system good. Please join me in thanking our speakers.